bacteria in Japan. So a lot of hue and cry around it, and I think it's only befitting that we have this CME at this juncture for Quest. So to start with the proceedings, may I request our dear Marina ma'am to say a word of prayer.
Thank you, Jesus, for this beautiful day. Thank you, Master, for helping all of us to assemble here, Lord Jesus, to update our knowledge, to hear from experts, and to help patients at large. Be with the speakers and all the audience. Help us to understand and seek questions and answers. We ask all this in the precious name of the Lord Jesus Christ. Amen.
From the Team Quest, we really appreciate the Department of Microbiology for taking up this responsibility of conducting this program. May I invite Professor and Head of Microbiology, Renu Matthew ma'am, to start off the program.
Very good morning to all of you. Thank you for coming, first of all. We have two experts in the field of infectious diseases today. And the first speaker is Dr. Adarsh Ailith K. He hails from Kannur. He did his MBBS and MD from Government Medical College, Calicut. And he did his DM, Infectious Disease, Adult Immunization and Travel Medicine from AIIMS, New Delhi, and also MNAMS. He is currently Assistant Professor, Consultant, and Head of Infectious Diseases and Adult Immunization in Amala Institute of Medical Sciences, Thrissur. From August 2023 onwards, he is there, and he has many publications to his credit, and a lot of achievements are there. If I tell all that, it will take more time. Since there are two speakers, we want to cut short. So he has other topics in medical books also, and his interest is in mainly nosocomial infections, infections in immunocompromised and travelers, antimicrobial stewardship, invasive fungal infections, tropical infections, travel medicine, and adult immunization. He also does teaching for UG and PG. So I welcome Dr. Adarsh to this session.
Good morning. At the outset, I would like to thank the Believers Church Medical College Hospital and Microbiology Department for inviting me for this talk. So my topic for today is diagnosis and management of nosocomial MDR bacterial infections. So I have, due to the time limits, I have concised it to just nosocomial MDR bacterial infections. So in this talk, so I'll be giving about a problem statement. Then we'll be seeing some basics about antimicrobial resistance in the MDR bacteria. And then we'll go on to some case scenarios and we'll discuss the management of such cases with the appraisal of the guidelines. And I don't have any conflicts of interest. So we know this thing, that is antimicrobial resistance is rapidly spreading up. This is posing economic burden on the healthcare, resulting in treatment failure, increased morbidity and mortality. And we know that the WHO has given a list of priority pathogens that have to be targeted when you consider an antimicrobial stewardship or hospital infection control program. So we have three groups: critical, high and medium priority groups. And in the critical priority group, we have the drug-resistant enterobacterials, which include our E. coli, Klebsiella, etc., resistant Acinetobacter baumannii, Then in the high priority group, we have the other organisms like Pseudomonas aeruginosa, methicillin-resistant Staph aureus, Enterococcus faecium, etc. Now, when we look into the drug resistance scenario in India, so this is based on the 2021 ICMR data. So you see that the carbapenem resistance rates in our Klebsiella and Acinetobacter, this is reaching almost 50%, and this is 21 data. So by this year, it would have definitely increased. It would have crossed 50%. Now, before going to the scenarios, it will be good if we know some of the resistance mechanisms which we observe in gram-negative bacteria. So the majority of the resistance in gram-negative bacteria are due to beta-lactamases. So these are enzymes which will degrade the beta-lactam antibiotics. So we know that beta-lactam antibiotics constitute the penicillins, cephalosporins, monobactam, and carbapenems. So there is a classification of this beta-lactamases. You call it as the amber classification. There are 4 classes, A, B, C, and D. So in the coming slides, you'll be coming across some of these terms like CTXM, KPC, IMP, VIM, NDM, etc. So these are basically different types of beta-lactamases. So class A of serine beta-lactamases, there are different types like TEM, SHV, CTXM, KPC. Here KPC is important because KPC is a carbapenemase which can degrade the carbapenems also. Now class B, you particularly call it as metallo-beta-lactamases. And these are very important in our scenario because most of our drug-resistant gram-negative bacteria harbor this metallo-beta-lactamases, among which NDM, that is the New Delhi metallo-beta-lactamase, is most important. Then you have class C, which you call it as the AMP-C beta-lactamases. And then you have class D, we have the OXA. OXA is also important. There are various types of OXA, like OXA 23, OXA 48, and various other types of OXA. So the prevalence of OXA also varies among bacteria. Like OXA 48, these are more prevalent in the enterobacterials, but OXA 23 is more prevalent in the Acinetobacter. And also there are differences in the activity of the beta-lactam and beta-lactam inhibitors, beta-lactamase inhibitors, when they act upon various of this resistance markers. So we'll be coming to that in detail in the coming slides. And it is not just beta-lactamases, there are non-beta-lactamase mediated resistance. Like if you consider a carbapenem resistant gram-negative bacteria, you can classify it into a carbapenemase producing bacteria and a non-carbapenemase producing bacteria. So there are non-carbapenemase mediated resistance which can be mutations in the porin channel. So that won't allow the antibiotic to enter into the bacterial cell. There can be efflux pumps, overexpression of efflux pumps, the antibiotic which has entered into the bacterial cell, which will be pumped out of the bacterial cell by the bacteria. So these are also mechanisms which you can observe in this bacteria. And how are you going to diagnose antimicrobial resistance? So definitely we have the conventional methods of diagnosing resistance. You do a phenotypic culture, and that is followed by antimicrobial susceptibility testing. You will understand which all organisms are susceptible and not. And the guidelines are endorsed by the CLSI and UCAST for diagnosing antimicrobial resistance from phenotypic cultures. But now we are in a way forward towards novel diagnosis of antimicrobial resistance. We have some rapid phenotypic AMR detection methods like the CARBA-R, CARBA-NP test. There are several tests like that where they'll be identifying the enzyme activity of this beta-lactamases. And now we have several molecular tests, PCR and multiplex PCR panels, which enable us to diagnose the particular microorganism and also identify resistance markers. So we are transitioning from traditional to the molecular methods with the help of multiplex PCR and multiplex PCR panels. These are approved for several infections, several samples, including blood culture, flag blood culture, respiratory specimens, stool, then joint fluid, other fluids, etc. So whatever I have discussed till now will be coming in the next slides as case scenario. So I think this will be the interesting part of this topic. So this is the first scenario. A 55-year-old male, diabetic, post-surgery for a fracture right neck of femur. He is catheterized. He is having fever, flank pain, and dysuria for 2 days. And now he is in hypotension. Blood culture and urine culture was sent. The blood culture has flagged. So if you have a flagged blood culture, you can use the molecular panel in that. So in our institute, we use the molecular panels by BioFire, and the BCID2 panel, this has shown the growth of, detected the growth of enterobacterial, that is Escherichia coli, and it is showing a resistance marker CTXM. We have seen that CTXM previously, so that is a class A beta-lactamase. So basically this CTXM, it is going to degrade all the cephalosporins, most of the cephalosporins. And ultimately, we have received the culture also. So both of the cultures have grown E. coli, and that is resistant to ceftriaxone. And it is showing susceptibility to piperacillin, tazobactam, and meropenem. So my question is, which antibiotic will you choose in this patient? Whether you go with piperacillin, tazobactam based on an antimicrobial stewardship practice, or whether you will treat with meropenem. So we must know the data and also the latest guideline appraisal. So studies, this was the Merino trial in 2018. They have compared the mortality in bloodstream infection due to ESBL. ESBL means extended spectrum beta-lactamase. That is one example, CTX. ESBL producing a bloodstream infection by E. coli or Klebsiella pneumoniae. They compared the mortality between two. So there was an increased mortality rate which was seen with the piperacillin tazobactam arm than with the meropenem arm. That was statistically significant. So that has proved, although this study had got some limitations, several other small trials have also shown increased risk of microbiological failure as well as mortality when you give piperacillin tazobactam in such a patient. So piptaz is not suggested for the treatment of infections outside of the urinary tract, which is caused by an ESBL producing enterobacterials, even if susceptibility is demonstrated. So the IDSA 23 guidelines, they tell like this. So if it is a cystitis by an ESBL producing enterobacterial, if it is susceptible to, so mostly this organism, they retain their susceptibility to common antibiotics like nitrofurantoin or cotrimoxazole. So if seen susceptible, this can be given. Now when it comes to pyelonephritis, so treatment of pyelonephritis also, that is classified based on the severity. It can be just confined to the urinary tract. It can go into the bloodstream and produce sepsis. So if it is just a pyelonephritis, you can treat with cotrimoxazole or levofloxacin if susceptible. Or if it is showing susceptibility to piptaz and carbapenem, you will be going with carbapenem, not piperacillin tazobactam. And aminoglycosides, usually they are not given as a monotherapy. And what about infections outside the urinary tract, like you have a VAP or a bloodstream infection? So here you will be going with carbapenems. If you have a bloodstream infection with ESBL enterobacterials, you treat with carbapenem. So where is piptaz here? So regarding piperacillin tazobactam, if you have initiated piperacillin tazobactam as an empirical therapy for uncomplicated cystitis, which was later identified as an ESBL producer. And if the patient is clinically improving, then there is no need to change or extend the antibiotic therapy. You can just complete the course with piperacillin tazobactam. So that is the indication. And regarding pyelonephritis without sepsis, of course, still we use piperacillin tazobactam in some selected cases. But if you have a patient who is having a suspected bloodstream infection, septic patient, toxic patient, go with the carbapenem. Okay, that was the first case. So next case, we have a 57-year-old female post total abdominal hysterectomy, day 3. Here also, symptoms suggestive of UTI. Urine culture is showing Enterobacter cloacae that was susceptible to ceftriaxone. Patient was started on ceftriaxone, but there is no clinical improvement after 3 days. What is the mechanism and how will you approach? So here we are seeing a particular organism, that is Enterobacter cloacae, that is also an enterobacterials, but when you see these organisms, that is Enterobacter cloacae, Klebsiella aerogenes, Citrobacter frondae, and 2 others as I've mentioned here. So these are organisms which produce a particular type of beta-lactamase, that is AMP-C. We have seen in the classification the class C amber beta-lactamase, that is AMP-C. So AMP-C is a beta-lactamase which can be induced. So when these organisms are exposed to antibiotics like cephalosporin or aminopenicillins, they will produce AMP-C, and AMP-C is going to degrade the this cephalosporins or the aminopenicillins. So that is the importance of AMP-C. So since this organism is a strong AMP-C producer, ceftriaxone is not a good option for this organism. Ceftriaxone is going to induce AMP-C and which will result in therapeutic failure. So how are you going to approach this case? And this was another study, that is the Merino-2 trial, where they have studied these organisms, these AMP-C producers, and where they have compared meropenem versus piperacillin tazobactam. Here also piperacillin tazobactam was inferior to meropenem. So for AMP-C producers, what antibiotic will you choose? So basically CLSA does not have any, they haven't endorsed any testing methods for AMP-C, but UCAST has. So these are the potent AMP-C inducer drugs, like the aminopenicillins and the first generation cephalosporins. But cefepime is a good antibiotic against AMP-C producer, but if that should be based upon the MIC of cefepime. If it is less than, if it is more than 4, then you don't use cefepime, you will have to prefer meropenem. So carbapenems are good choice for AMP-C producers, and among carbapenem, meropenem is the best choice. Ceftriaxone and piperacillin tazobactam shouldn't be used for treatment for AMP-C producers. But if it is an AMP-C cystitis and if the organism is retaining its susceptibility to nitrofurantoin or cotrimoxazole, you can use these 2 drugs. Third scenario, 66-year-old male, CA stomach post-gastrectomy. On day 2, patient has cough, expectoration, breathlessness. Saturation 90% room air. This is the chest X-ray. There is a patch. And he was started on piperacillin tazobactam empirically. But on day 4, patient deteriorated and is intubated in view of respiratory distress. Antibiotics upgraded to meropenem and teicoplanin. A mini BAL was done. And that has detected Klebsiella pneumonia. And in this pneumo plus panel, you'll get the bin count also. Count, it is difficult to interpret, but you can use it when you find 2 or 3 organisms in order to identify the main pathogen. And multiple resistance markers, CTXM is there, NDM, the metallobeta-lactamase, OXA48, VIM. So how are you going to approach this case? So when you have multiple such markers, all this will make the carbapenems inactive. So this organism is definitely a carbapenem-resistant Klebsiella pneumonia. And of course, we have got the culture report resistant to all antibiotics, and you have just an intermediate susceptibility to the polymyxins. So here, this is a scenario where you will be going to use polymyxin. So here, whether you will use polymyxin, whether you used alone or in a combination, or whether you will prefer some other drugs, we'll see. And we know that polymyxins are bactericidal drugs. You have polymyxin B and E. Polymyxin E is colistin. Understand that there is no susceptible category for polymyxin. If you find a culture report with polymyxin, you will be having either intermediate or resistant category. And the intermediate, we'll consider it as to use it for the treatment. And polymyxin, it is active against most of the gram-negative bacteria, especially drug-resistant, Acinetobacter, Enterobacter, Pseudomonas aerogenesa. But it is not active against gram-positive organisms and anaerobes. And there are also some gram-negatives which are intrinsically resistant to polymyxin, like Serratia, Proteus providentium organella. Together we call this Proteus providentium organella as the proteate tribe. Then Burkholderia. And Stenotrophomonas, it is not intrinsically resistant, but CLSA has not given how to test susceptibility to polymyxin for Stenotrophomonas, and also all gram-positive. So polymyxin, although it covers many organisms, still it doesn't cover some of the important organisms. So which polymyxin you will prefer? So when you have a comparison between colistin and polymyxin B, colistin is administered as a prodrug, whereas polymyxin, it is administered in the active form. It has got more rapid and predictable action. Nephrotoxicity is very less with polymyxin B compared to colistin. And colistin is only preferred in UTI because it has got an excellent urinary penetration. Polymyxin doesn't have that. So all infections outside of the urinary tract, you will prefer polymyxin B. Now this patient on day 3, the creatinine has jumped to 2.8. So patient on polymyxin therapy is developing AKI. So dose modification is required in option A, polymyxin B only, B, colistin only, required in both or not required in both. So this is required only for colistin. For polymyxin B, there is no recommended renal dose adjustment. And very rarely only you find renal injury with polymyxin B, and that too after excluding all other causes of renal injury, including sepsis. So the maintenance dose of polymyxin B need not be adjusted if the patient has developed renal impairment, because if you decrease the dose, the antibiotic is going to be ineffective. Polymyxins have got unreliable pharmacokinetic, pharmacodynamic parameters. You cannot predict how much time and how much amount the drug lies in the blood and within how much time it is getting excreted. So it is very unpredictable. So, and another role, you have a practice of giving inhaled polymyxin, inhaled colistin for VAP. So the latest recommendations have told like there is no role for that. We don't have any evidence to support giving an inhaled antibiotic because the concentration of antibiotic you are giving in the inhaled form is very less to overcome the MIC for that organism in the respiratory tract. So polymyxins, even polymyxin B, these are not reliable because when given IV, it results in a poor concentration in the lungs. There is a rapid renal clearance, so steady state is not achieved, and high risk of nephrotoxicity with colistin. And neurotoxicity is also an issue when you give it for a prolonged duration, especially in critically ill patients. So in the scenario which I have shown, of course, we have only polymyxin currently available for that particular patient. You will have to use polymyxin, but still we have other options that we'll see in the next scenario. Diabetic hypertensive post-transplant CKD on dialysis for pulmonary edema. Now complaining of abdominal pain, dysuria and fever. He has a history of recurrent UTI. Now he has a right renal angle tenderness. Blood and urine cultures were sent. So here you see again a Klebsiella pneumonia. So this has got CT-XM and OXA48. So here we are lucky that this has got only CT-XM and OXA48. The metallo-beta-lactamases are not detected. So here we have some other options. So there comes the role of ceftazidime avibactam. So a study, the Crackle study, which has compared ceftazidime avibactam with colistin, have definitely proved the superiority of ceftazidime avibactam. And what is this actually? So this is a novel beta-lactamase inhibitor combination. It covers all the ESBLs, it covers the AMC, it covers the KPC among the class A beta-lactamase, it will cover the OXA48 producing enterobacterials. And also some of the drug-resistant Pseudomonas aeruginosa isolates. But this is not useful in Acinetobacter. You cannot use it in Acinetobacter, and it doesn't degrade the metallo-beta-lactamases. So in the presence of a metallo-beta-lactamase, ceftazidime avibactam is going to be ineffective. So currently the FDA-approved indications include complicated intra-abdominal infections, UTI, hospital-acquired pneumonia, and the dose is 2.5 gram Q8H. So in the scenario, which I have seen initially where we discussed polymyxin, that Klebsiella was showing all this. There was OXA48, there was CT-XM, there was metallo-beta-lactamases. So, okay, this is the culture report of this case which I have discussed, which is showing susceptibility to ceftazidime avibactam. So what is the role of a combination of ceftazidime avibactam with aztreonam? So aztreonam, that is a monobactam, it has got activity against the metallo-beta-lactamases, including the NDM. But aztreonam will be degraded by the other beta-lactamases like KPC and OXA48. So ceftazidime avibactam can degrade OXA48, but it will be degraded by the metallo-beta-lactamases. So then comes the concept of why combining these two, you can target the NDM producers as well as the OXA48 and KPC producers. So when you are using ceftazidime avibactam and aztreonam, you will be giving both these drugs simultaneously, either through two different cannula or through two different ports of the same cannula, and it is infused over 3 hours. So you have a testing for the synergy between ceftazidime avibactam and aztreonam, which it is done in our microbiology lab. Hopefully it will be done here also. And it is not like a rule that all enterobacterials with those resistant markers will be susceptible to the cefta-avi aztreonam. We of course see Klebsiella which are resistant to cefta-avi aztreonam combination. So if you have a scenario where you have started with polymyxin, request your microbiology lab to look for the synergy between cefta-avi aztreonam, and if the synergy is found to be positive, you change polymyxin B to ceftazidime avibactam aztreonam combination, because that is going to be more successful in the treatment, in the therapy. If the synergy test is negative, then of course you will have to continue with the polymyxin B. And this drug is now used everywhere rampantly. I have seen some physicians giving cefta-avi as empirical therapy. So in an antimicrobial stewardship practice, so soon this will become our next meropenem, and we'll have to go for other antibiotic options. So can we still use meropenem in carbapenem-resistant enterobacterial infection? So there will be scenarios where you don't have access to any of these drugs, or cost issues, patient cannot afford. You are forced to use some antibiotics which are resistant. So if you have an isolate whose MIC is less than 16 for meropenem, you can still administer meropenem as a high dose prolonged infusion, like a 3-hour infusion, or you can use the whole dose as a 24-hour infusion in combination with polymyxin or tigecycline. We'll be coming to discussion of tigecycline. So this is based on the pharmacokinetic property of the drug. So the guideline appraisal for treating carbapenem-resistant enterobacterials, which is producing these resistance markers. For CRE cystitis, of course, it is almost similar to what we have discussed. If they are retaining susceptibility to the common drugs, you can go with that. For CRE outside urinary tract, for KPC and OXA48 producers, you can go with ceftazidime avibactam. If NDM producer is there, you go with cefta-avi with aztreonam. And tigecycline is not useful for UTI and bloodstream infection. Don't use tigecycline in a patient who is having sepsis as well as UTI, because this is not going to stay in the blood. It is not going to penetrate the urinary tract. And polymyxins, these are not preferred for CRE. You will be using polymyxin only as part of a combination therapy. Next scenario, 45-year-old male, corrosive injury esophagus, managed with endoscopic dilatation. He is on total parenteral nutrition, developed fever, and blood cultures were drawn. So blood culture is showing Acinetobacter baumannii complex. Of course, none of the resistance markers were detected. However, when the culture report came, so this is showing an extensively drug-resistant Acinetobacter, carbapenem-resistant Acinetobacter, and it is showing an intermediate susceptibility to colistin and tigecycline. So when you consider CRAB, you call it as CRAB, it is very difficult to differentiate between a colonization versus a true infection when it is isolated from a respiratory specimen or wounds. And CRAB are highly drug-resistant. They produce some other carbapenemases like OXA23 in addition to the metallo-beta-lactamases. They have multiple penicillin-binding protein mutations. And we don't have a clear standard of care antibiotic regimen against which we can assess the effectiveness of other treatment regimens. So we have these drugs available for treating Acinetobacter. We have high-dose sulbactam given as 3 gram Q8H, or high-dose ampicillin sulbactam 9 gram Q8H. And tigecycline, of course, is active, high-dose tigecycline. Similarly, high-dose minocycline. So nearly 50% of the CRAB isolates can show susceptibility to minocycline also. And always treat a crab infection with a combination therapy. You can use polymyxin as part of the combination therapy. So we have another form of sulbactam available, that is cefoperazone sulbactam, but we don't have data to suggest the efficacy of cefoperazone sulbactam. And high dose cefoperazone sulbactam is also not preferred because it can produce coagulopathy. And tigecycline, if you use as a monotherapy, it has got a higher mortality if you use as a monotherapy in ventilator-associated pneumonia. And for here also, there is no role for nebulized antibiotics. So IDSA recommends to treat crab infection with a combination of two active agents, among which the first agent is a sulbactam, either pure sulbactam or high-dose pure sulbactam or ampicillin sulbactam. You can combine with either a polymyxin or minocycline or tigecycline in high dose. And you can use the extended infusion concept of meropenem if the MIC is less than 16, but that is only as part of a 3-drug combination. Along with the 2 drugs you have given, you can add a high-dose meropenem. And cefiderocol is the latest drug. We don't have this drug, so I'm not going to details of that drug. Once the patient shows improvement, you can step down to a single active agent. So this is a 70-year-old female ILD who has developed VAP. We are seeing this culture report, Pseudomonas aeruginosa. It is susceptible to ceftazidime. It is susceptible to piperacillin tazobactam, but it is resistant to carbapenem. So you can see such reports in Pseudomonas aeruginosa. So this is not due to beta-lactamase, but this is mostly due to mutations in the porin channels or in the multi-drug efflux pumps. So this porin mutation or efflux pumps, these are not allowing the carbapenems to act, but the other drugs are saved. So Pseudomonas, it is also very difficult to treat. You have MDR Pseudomonas as well as difficult to treat Pseudomonas. So DTR Pseudomonas is more concerning. It is not susceptible to piptas, ceftazidime, cefepime, aztreonam, meropenem, imipenem, and the fluoroquinolones. So in the scenario which we have seen, so that was not a DTR Pseudomonas because it was retaining its susceptibility to ceftazidime and piperacillin tazobactam. So when you how will you treat that? How will you treat? Are you like happy or confident to start ceftazidime or piptas for that patient? So the IDSA says if the Pseudomonas is susceptible to the traditional non-carbapenem beta-lactam agents and carbapenem, susceptible to both, you prefer the traditional non-carbapenem agents. So that is as part of a antimicrobial stewardship practice. But if it is carbapenem resistant but susceptible to the traditional beta-lactam agents, then you go with the traditional agent as a high-dose extended infusion, and you will have to repeat the culture after 3 to 4 days of therapy because Pseudomonas has a property to develop an acquired drug resistance after getting exposure to the drugs. So after 3 or 4 days of therapy, you repeat the particular culture and see if there is growth and see the antimicrobial susceptibility to pattern. Now, if it is a critically ill patient, so same report like we have seen that ILD, VAP, critically ill patient, it is showing susceptibility to ceftazidime and piperacillin tazobactam but resistant to carbapenem. In such cases, you go with the novel beta-lactam agents like the novel beta-lactam agents which include the ceftazidime, avibactam. So here, if it is a critically ill patient, you are not confident to start ceftazidime or piperacillin tazobactam, and carbapenems are resistant. So they recommend to go with ceftazidime, avibactam. That is the only novel beta-lactam agent which we have. Other novel BLIs like ceftriaxone, tazobactam, cefepime, cidibactam are currently not available in India. And these are the drugs which are used for Pseudomonas elsewhere. So in this particular case, since the patient is having a VAP, and based on the severity of the VAP, you can decide whether to give ceftazidime or piperacillin tazobactam or go with the newer BLIs. So treatment options in India for DTR Pseudomonas are very limited because you won't find Pseudomonas getting susceptibility to ceftazidime, avibactam everywhere. Mostly you will find it resistant. Rare isolates can be susceptible. And here also you can follow the synergy with aztreonam. If it is found synergetic with aztreonam, you can give combination of ceftazidime avibactam with aztreonam. And of course, we'll have to work more to get the other drugs available. But our concerns are more of crab and carbapenem resistant enterobacterials than Pseudomonas, because Pseudomonas is less prevalent in our setting. So that is why we are not behind this organism much. And should you use a combination therapy in DTR Pseudomonas? So if it is susceptible to the newer BLBLI like ceftazidime avibactam, just single drug is enough. And if no preferred agent demonstrate activity against DTR Pseudomonas, IDSA is telling to combine tobramycin if it is susceptible with the newer beta-lactam agent with the MIC closest to the susceptibility breakpoint. Like you have a Pseudomonas aeruginosa which is resistant to carbapenem, piperacillin, tazobactam, everything, but and resistant to cefta-avi, ceftriaxone, tazobactam, cefepime, cidibactam, showing susceptibility to tobramycin or amikacin. You can combine one of this aminoglycoside with the BLBLI which is having the lowest MIC. So this looks complicated because we don't have other BLBLIs to compare the MIC. We have only ceftazidime avibactam as the newest BLBLI. 55-year-old female, diabetic, CKD 5 on HD, high-grade fevers in 7 days. Blood culture has grown this. Enterococcus faecium. So till now I was discussing about the gram-negative bacteria. To discuss about gram-positive bacteria, that is also a tedious process because you have MRSA. But I thought I will discuss something about vancomycin-resistant enterococcus because this is getting more prevalent in the current scenario. So when you consider enterococcus species, speciation is very important. You have two important species, Faecalis and Faecium. Most common is Faecalis. Faecalis is more susceptible to the beta-lactam agents, but Faecium is more resistant, and 90% of Faecium can be resistant to vancomycin. You call it as a vancomycin-resistant enterococcus. So the recommended treatment for enterococcus is a combination of beta-lactam with aminoglycoside because that is going to produce a synergy. And there are only two aminoglycoside recommended, gentamicin or streptomycin. And beta-lactams, the recommended beta-lactams include ampicillin or penicillin if it is susceptible. And there are only few cephalosporins which retain their activity to enterococcus. We'll be seeing that. Now, this synergy is abolished when there is a high-level resistance to gentamicin. You call it as HLAR, high-level aminoglycoside resistance. If this is reported, then that is, this synergy is not going to work. This combination is not going to work. So the next concept is a combination of two beta-lactams, that is cephalosporin and ampicillin. So basically the mechanism is by saturating different types of penicillin-binding proteins. There are only few cephalosporins which you can use, like ceftriaxone or cefotaxime, which are available to us. You have new cephalosporins like ceftarolin or ceftobiprole, which also have activity against enterococcus faecium. So this combination can be used. So when you compare a combination with aminoglycoside and this combination, this will be less nephrotoxic. You can safely use. Now when you come to a treatment of enterococcus faecium, so this is for vancomycin. This is an enterococcus faecium, as we have seen. It can be classified into an endocarditis and non-endocarditis. If there is an endocarditis, then the treatment will go with a daptomycin-based regimen. If it is a simple bloodstream infection without an endocarditis, you can go with linezolid or a combination of ampicillin with aminoglycoside if there is no high-level resistance to aminoglycoside, or a combination of daptomycin with beta-lactam. And other options like tigecycline, it cannot be used in a bloodstream infection. You can use it for a wound infection, that will be appropriate. And fosfomycin, that is also a good drug, especially if you have a UTI with a vancomycin-resistant enterococcus faecium, fosfomycin will be a good option. So enterococcus isolates, especially enterococcus faecium, these are very difficult to treat, and preferably you'll go with the combination therapy. And just this is a summary of how long you should use antibiotics. So we see very prolonged duration of antibiotics for many syndromes. So for a HAP or a VAP, just 7 to 8 days after a clinical improvement is enough. And if it is a catheter-associated UTI with cystitis, 5 to 7 days. And pyelonephritis, 10 to 14 days. And for bloodstream infection, in general, 10 to 14 days. But this can vary with the organism. Like if you get a Staphylococcus aureus or Pseudomonas aeruginosa in a bloodstream, you might have to prolong the duration. For a skin and soft tissue infection or a surgical site infection, 5 to 10 days is enough. And intra-abdominal, depending on the source control, you will go from 5 to 14 days. So always go with the antibiotic duration also. So we have discussed some of the common organisms which you see in your daily practice. So to summarize, molecular diagnostics, they give rapid results and they help in antimicrobial stewardship. And prefer polymyxin B in all infections except UTI. Don't use polymyxin B in UTI. And colistin, it is nearly out. We are using it only in some cases of UTI. No renal dose modifications for polymyxin B. Ceftaz, synergy test with aztreonam whenever needed. And don't use ceftazidime avibactam for Acinetobacter. It is not going to work. Tigecycline, avoid tigecycline in sepsis and avoid using it as a monotherapy in VAP. Use it as a combination therapy. But tigecycline can be used as a monotherapy in a complicated intra-abdominal infection or a complicated skin and soft tissue infection. DTR Pseudomonas, although less common, the available antibiotics are limited. And vancomycin resistant enterococci, preferably, you go with the combination therapy. So with that, I would like to end my talk. Thank you. Thank you for listening.
Thank you, Dr. Ashish, for that very informative talk. We'll go on to the next part of it. Dr. Devjani, she's the lead for medical affairs for BioMerieu South Asia. She's also a clinical microbiologist. She did her MD microbiology from Lady Hardinge Medical College, New Delhi, and has got 12 years of experience. A lot of accolades are there. I'm not describing anything. Over to Dr. Devjani. There is my, I think it is.
Thank you so much, ma'am, for the kind introduction, and thank you, Dr. Adarsh, for the elaborate presentation. And I'll be talking about role of syndromic testing in better patient management. And what I'll be talking about is, I'll be talking about 6 infectious disease conditions which present diagnostic dilemma on a daily basis to every clinician, every microbiologist, and which has an impact on patient outcome as well as economic burden. So I'll be talking about respiratory infections, upper respiratory tract infection, lower respiratory tract infection, sepsis, GI infections, meningoencephalitis, as well as joint infections. So I'll be talking about how syndromic multiplex PCR testing helps in each of these conditions, and I'll be talking about 6 panels. And when I'll be talking about the 6 panels that are there with BioFire, I'll be deep diving into what are the unmet needs with standard of care microbiological traditional testing, as well as I'll be going through certain case scenarios where multiplex PCR testing has particularly helped. We'll be talking about recent guidelines that are there, and also we'll be talking about various publications. So that is the outline of my talk. So first I'll talk about the pneumonia panel. So I start with the pneumonia panel first because this is one test, the one BioFire, which requires a lot of understanding. It is not just the machine report that comes out, there is a lot of interpretation challenges. So before starting with that, I'll talk about how traditional testing, what are the unmet needs of traditional testing. So this is the landmark study by Jain et al. In the NEJM in 2015, where they found out that with traditional microbiological culture techniques, in a critical condition like pneumonia, only the clinical etiology was not found in 62% of cases. The traditional testing misses atypical infection diagnosis, viral detections are missed, co-detections are missed, and sometimes we have to rely on convalescent serology, and by that time it is too late. So this is the landmark study which talks about these unmet needs. So with that context, what does the pneumonia panel talk about? It gives you bacterial detection in a semi-quantitative manner. So there are 15 bacteria which are given semi-quantitatively, and when I talk about the semi-quantification, I'll talk about the rationale behind it. Why is it semi-quantitatively detected? There are atypical bacteria which are detected by the biofire as well as viruses. So classically, atypical bacteria and viral detections won't be colonizations. These would be pathogens. So that's where the semi-quantification is required. So I'll start with the first frequently asked question. Whenever we get a microbiology report, particularly from samples like sputum, BAL, ETA, how do I differentiate between a colonizer and a pathogen? So to make things simple, in 2004, IDSA came up with guidelines for culture. So in culture, the units are colony forming units per ml. So IDSA in 2004 came up with guidelines where they gave cutoffs for BAL fluid, ETA as well as sputum. So BAL is the most aseptically collected sample. So that's why they kept the cutoff for BAL fluid at 10 to the power 4 CFU per ml, and for ETA and sputum they kept it higher up, 10 to the power 6 CFU per ml. But in 2016 they moved away from absolute cutoffs, but they now talk about, they emphasize on relative ranking. So whenever there are many organisms that are detected, so what they say that you do a relative ranking of which is the most predominant organism. So the more predominant it is, the more is the likelihood of it being a pathogen. So same is the principle of biofire, and that's why the semi-quantification for the 15 bacteria, which helps in differentiating between a colonizer and a pathogen by the increased likelihood if the predominance is higher. So how does the biofire report the colonies? So in culture, as the units are CFU per ml, in biofire it is copies per ml, and I'll talk about how both correlate, or do they even correlate. So I'll talk about it in detail. So whenever I want to differentiate between a colonizer and pathogen, there are three things that are very important. Where is the pneumonia panel to be used? So the pneumonia panel should not be used to screen all patients. It should be used to say whether the patient has pneumonia or not. Rather, a patient fitting in the clinical picture of pneumonia, only in those patients is the intended use of pneumonia panel. Second, it should not be used as a standalone test. It should be taken in a holistic way, and it can be used for HAB, VAP as well as community acquired pneumonia. Sample type is BAL, ETA, mini BAL as well as sputum. So second is the sample type. So as we know, as I've said, BAL fluid is the most aseptically collected sample. So whichever organisms that are picked up in BAL, they have a higher relevance compared to a sputum sample which is not properly collected, and no matter how well the patient gives an expectorated sample, colonizers, because during expectoration would be coming in the sample. So that's where the sanctity of the sample type is very important. There are various publications which say that sputum would have oral flora and would have higher chances of colonization. Third, how is my sample type? So if the sample, there is no prerequisite as such for biofire to reject the sample. However, the good lab practices should be there in play. And what do the good lab practices say? Whenever a sputum sample is received at the lab, we do a Bartlett score or a Q scoring, where the principle is the more the epithelial cells, the higher is the chances of it being a saliva. And in BAL fluid, if there are alveolar macrophages, then it is a more representative sample. So with those three things, these three prerequisites, in which patients I am running the test, what is my sample type, and how good is my sample. Then when I look at the biofire report, does the biofire report give a cutoff? So can I say based on the copies per ml which is a colonizer and which is a pathogen? So the answer is no. So there are no absolute cutoffs. So there are 69 papers that were reviewed, and 31 papers they gave a cutoff, but there was no consensus. So people are trying to figure out, but I'll talk about what each copies per ml is usually indicative of. But then there is no consensus and there is no absolute cutoff. It is still relative ranking. So we've talked at large about the AMR genes and what BioFire, the pneumonia panel, gives you detection on AMR genes as well. So the AMR gene detection, how do we interpret the AMR gene detection in pneumonia panel? These are only predictive. So whenever you are getting the report, you would know that which is the therapy that is likely to fail. So if it's a CTXM, I would not be giving cephalosporins in those patients. So these are the antibiotics which would not work. So as I have mentioned, in the except category, rest of them, the clinician should not be starting. So I start with one case. So this is one case which was received at my lab when I was working in my previous organization. So this was from Fortis, Noida, 65-year-old female presented with shock in 2019. So this is pre-COVID era. Patient was on inotropic support and BiPAP. And this is what the X-ray looks like, left upper lobe pneumonia. Now the patient was given all the cocktail of antibiotics, antifungals, antivirals, and after the patient was stabilized, bronchoscopy was done. The bowel fluid reaches my lab, and this is what was detected: 10 to the power 7 strep pneumoniae and 10 to the power 5 Haemophilus, and there is a bystander virus, innocent virus, that is rhinovirus/enterovirus. So the report is out. Based on this, targeted therapy started, Claribid and Targocid. Culture results did not yield anything. So this again highlights the standard of care testing, how it misses detections. And this is how there is radiological clearance after 7 days and the patient gets discharged. So this is what the impact the targeted therapy had. It was started within 24 hours and the ICU stay was minimized by 7 days. So this is one more case, a 75-year-old female presents at a tertiary care facility with respiratory failure, was started on standard cap regime, but however deteriorates. Presents to the tertiary care facility, the X-ray chest looks like this. Initiated on piptaz and clarithromycin, not getting fine. Finally, a bile fluid is sent for BioFire, and it is para-influenza virus as well as MSSA. Now, when it's an MSSA, it is always better to start. Vanco is not the drug of choice for MSSA. The drug of choice is a more de-escalated antibiotic which is targeted and tapered. So flucloxacillin, vancomycin in case of MSSA would lead to bacteriological relapse and treatment failure. So fluclox could be started, and of course fungus is not detected on BioFire, but the bile culture grew aspergillus and galactomannan was also positive. So that's why an antifungal was added and the patient improved. So with those two cases, we'll talk about what do the guidelines say when we talk about community acquired pneumonia. So in 2021, the ATS, they came up with clear-cut guidelines that it is non-influenza PCR testing where all it should be done. So an expanded multiplex PCR testing should be done in all inpatients with severe CAP and in all immunocompromised patients with community acquired pneumonia. 2023, there were two major guidelines that came up. One was from the European Respiratory Society, where they, because of the high sensitivity as well as the high specificity of multiplex PCR testing, they said the greatest potential of multiplex PCR testing is in its ability to rapidly adjust for unwarranted broad spectrum antibiotics that we start for Acinetobacter and Pseudomonas, which not only add to the AMR but also add to toxicities. Second guideline, so then this is Clostridioides difficile, which is on the rise because of several antibiotics. Now in October 2023, following European Respiratory Society, the IDSA also came up with guidelines which they say for community acquired pneumonia, as highlighted, if it is available, it should be done in all cases of community acquired pneumonia, and it is not only viral testing but also an expanded bacterial testing that needs to be done. So in immunocompromised patients, always there has been a paucity of symptoms would be there, and there has always been a paucity of guidelines. So based on the paucity of the data that is there in the immunosuppressed populations, the American Transplant Society, they convened a consensus conference where they talked about how negative but a biofire positive. I am sure that is one experience. So how do they equate? How the culture report equates with the biofire report? So usually it won't be the same. And so how it works? It is usually biofire panel would, because by virtue biofire is PCR, and PCR detects both viable organism as well as non-viable organism, whereas culture would only detect what grows, what is living, what is viable. So they would never be equal. But when are they equal? So usually what is seen, when even from a personal experience, usually the bacteria that are in the biofire 10 to the power 5 copies per ml onwards, they start showing a higher concordance on culture. So the higher the copies per ml, they start getting picked up in culture. Why? Number one, as I said, usually the culture would pick up only what's viable. Second, PCR is more sensitive. So because of these two principles, so the most common reason of organism not growing in culture is that the patient is already on antibiotics. Particularly in tertiary care facilities, they are always flushed with antibiotics when they reach the tertiary care facility. Secondly, fastidious organisms, culture would not be able to pick, like Mycoplasma, Chlamydia and Legionella. So this biofire picking up positive but culture detecting negative is not actually biofire false positive, it is actually culture false negative. So, and this has been shown by several publications, including several Journal of Clinical Microbiology, where they have found out it is biofire true positive. It has been compared with the comparator method. So how do they correlate? Usually the pneumonia panel would give one log higher. So if it is 10 to the power 3 CFU per ml in culture, it is usually 10 to the power 4 copies per ml on biofire usually. So that is how it is 1 log higher than the culture. So this is what I have talked about, why it won't be picked up in culture. Most common reason is patient already on antibiotics. Secondly, because of the lower sensitivity, sometimes these organisms are reported as normal flora by the lab because it is in the range of 10 to the power 3 CFU per ml. So these are published in Buchan et al. Study. This was a landmark study done on pneumonia panel. 259 bile fluid samples in HAP-VAP patients were analyzed, and what they found out was that there was a higher concordance, 93.2% concordance when it was 10 to the power 5 copies per ml and onwards. What they found out was the organisms that were getting detected in the 10 to the power 4 copies per ml have historically been underreported in the traditional scheme of things, because they would be 10 to the power 3 or lesser, and that those would be declared as normal flora. So the clinical impact of this bucket of samples, this bucket of load of organisms is yet to be validated, how much impact it has and whether we disregard it or not. So because it is more sensitive, definitely there would be more organisms picked up and multiple detections. So would that mean more of escalations? So the answer is no. In the Buchan et al. Study, there was approximately 80% of antibiotic modifications were actually de-escalations, and it led to lesser antibiotic days, 3.8 days per antibiotic. So there is one more answer to how do I differentiate between colonizer and pathogen. So we look at, as I said in the beginning, we do not look at the test as a standalone solution. We should also look at the host response. So there are several studies which have compared procalcitonin. So they found out one particular interesting finding. So this is the latest publication in 2024, where they found out that in patients who had 10 to the power 6 or 7 copies per ml, the procalcitonin was higher. So this is how we can correlate, and it is a holistic diagnosis. So I will not go into the details of it. The several evidence there is globally, as well as Indian publications are coming up. We are also having a multicentric journal on community acquired pneumonia, where will be having more than 10 centers working on pneumonia panel. So there are several international journals which have given good results. So I'll talk about the upper respiratory panel. So the upper respiratory panel, the sample type is the same sample we used to collect for COVID, that is the nasopharyngeal swab. And so before COVID, no one used to bother about what organism is there causing the upper respiratory tract infection, but COVID, for the better or the worse, has changed the mindset, and people want to know. So there are several reasons why. During COVID, all the other viruses had gone on a holiday, but after COVID, every virus is back. So we had a very big viral season during 2022, 2023. There was influenza A, influenza B, adenovirus, RSV, metapneumovirus. So all the viruses are now back, and there are multiple detections or co-infections that are happening. So this is how the RP 2.1 looks. So there are 22 targets. This has less of bacteria, and the sample type is nasopharyngeal swab. And whenever we are diagnosing respiratory infection, we do not interchange or tweak the samples. Upper respiratory panel has to have the nasopharyngeal swab, and lower respiratory panel works only on the pneumonia panel. So this is one case. This is a pediatric patient, 35-day-old child, presents with RDS, respiratory distress, poor oxygen saturation, diagnosed with viral bronchiolitis. Now the patient is worsening. There are antigen tests that are done which are negative, RSV, influenza antigen negative. AMPI was initiated. However, it progresses, bilateral pneumonia. Patient is now started on ceftriaxone as well as vancomycin. Patient requires ECMO. This is how the X-ray chest is progressing. There is progressive multifocal airspace opacification by day 4, total volume loss. And now, after so much time, when nothing is growing, biofire is done, and the biofire says it's a Bordetella pertussis. Now the targeted therapy is started, azithromycin is started, and the patient improves. However, the patient has had sequelae, but the patient would have had a totally different outcome had the biofire not been done, because azithromycin would not have been started. So what does this case also signify? So pertussis is again coming up. So pertussis during COVID times, the universal immunization schedule of children was not properly followed, and that's why pertussis is coming up in a big way. There in adults also there is waning immunity. So what BioFire does, BioFire also helps detect unsuspected pathogens. So when the clinician is not even suspecting, when you're having a broad grouping of organisms in one test, you would be able to detect those unsuspected pathogens as well. So of course RSV previously was only 14% 20 years back, now it's 40%. So there are multiple viruses and bacteria which need to be taken care of. So one question I would like to answer, which panel do I run when? When do I run the upper respiratory panel? When do I run the lower respiratory panel? So definitely it depends on the clinical picture. So if it's an upper respiratory tract infection, definitely I'll do the upper respiratory panel. Secondly, if it's a LRTI, I'll go for the pneumonia panel. Second is what is the sample type I am getting. So the most difficult sample to get is BAL. And BAL, we do not do bronchoscopy on all patients, and to diagnose LRTI, we would require, if you are not going for invasive sampling, we would require sputum. But in pediatric patients, sputum we can't get. So there are several reasons or contraindications to getting a proper lower respiratory sample. So in those set of patients who are having pneumonia, lower respiratory tract infection, and in whom I can't get that lower respiratory tract sample, an upper respiratory panel can be helpful. It can act as a surrogate, because viruses that would be there in the lung would also be there in the nasopharyngeal swab. So with that intent, so it can act as a surrogate. But having said that, it won't have the organisms that are there in the pneumonia panel, which are more comprehensive. Secondly, 10 to the 15% times it may be missed. So because initially viruses would be there multiplying in the nasopharyngeal cells, but later on they will be residing in the lungs. So that, with that intent, the upper respiratory panel can be used if we are not able to get the lower respiratory tract sample. But the upper respiratory panel, again I would reiterate, it has to be run only on the nasopharyngeal swab. So now this is the third syndrome, meningoencephalitis. I'll rush through this because we have, how many pediatricians are there? So we know why I ask, particularly in children. Children, whenever they, particularly if they are 3 months, up to 3 months, they are presenting with sepsis, a workup is done, a sepsis workup is done, urine culture, blood culture, and CSF is taken. So those are the microbiological testing that are done. And CSF, statistics suggest that in small children, up to 35% of times you would have a failed lumbar puncture, and in those cases empiric antibiotics would have to be started in up to 30% of patients without knowing the diagnosis. So, and there is second challenge that is there with the diagnosis of meningoencephalitis, that is CSF, the volume. So volume is so precious that sometimes it leads to prioritization of testing. So there is a lot of back and forth between the microbiology and the clinician, that I have only this X amount of sample, you prioritize. And in that prioritization, sometimes the diagnosis, and most of the times the diagnosis can be lost. So with that, what are the challenges or what are the consequences of misdiagnosis? So this is one case that I present, 62-year-old female, previous history of endometrial carcinoma, presence with depression, hypertension, altered behavior, and there was possible seizure at the time of presentation. There was no fever. The patient was started on levetiracetam. This was in a peripheral setup where a CT was done, and there was hypodensity in the left temporal lobe, and the TTE was normal. Patient deteriorates, comes to the tertiary care facility where an MRI is done, and this is classical viral encephalitis, which was misdiagnosed on the CT. So this is T2 weighted FLAIR image where there is hyperintensity of the mesiotemporal lobe, and which was missed. So BioFire says it is HSV1 positive. Finally, although the patient is started on treatment, the patient has already deteriorated. So this is what are the consequences of misdiagnosis if it is not done at the right time. HSV encephalitis, if it is not detected and if the acyclovir is not started within the right time, after 7 days, it can lead to more than 70% bad outcome. Similarly, bacterial meningitis, if I am not starting with the right therapy within the golden hour, it can lead to 80% mortality and even 20% neurological sequelae. This is second case I'll talk about is how BioFire helps in detecting unsuspected pathogens. We know VZV is a very uncommon pathogen causing meningitis. So this is one case where I'll talk about. So these are published cases. There are only handful of cases, but it's there. So this is a 16-year-old male immunocompetent patient. There is no rash, nothing, and the patient has had altered behavior. This is how the vitals and the findings look like on examination. So patient is unwell, there is CNS disturbance, everything is coming out normal, there is no abnormality detected. The lumbar puncture, the CSF shows there is globulin positive, suggestive of infection. There is low glucose and high protein. So low glucose, high protein, usually now where does it go? It can be now, either it can go bacterial, it can either go viral, it can go both ways. So in the old scheme of things, we would do multiple testing, as I said, and then it would take time. Certain PCRs would require batch testing. However, fast forward, if we do a BioFire, the VZV is picked up much earlier on the same day. So this is the case that was published. This patient was immunocompetent without rash. So this condition is called zoster sine herpetae. So in that patient, VZV was detected. Secondly, hypoglycorrhea or low glucose can also be there in viral infections, viral meningitis, particularly mumps, measles, even VZV. So they can also present with, so these atypical presentations, these unsuspected pathogens can be detected. So third is very easy. This is a viral meningitis. The most common cause of viral meningitis is enterovirus, and this was detected in this patient. So CSF is the sample type, of course, but the point I want to highlight is that sample type, the sample volume is 200 microliter only. So that is only 0.2 ml required. So that is, you don't need to prioritize. You can get an answer to 14 organisms in one go. However, if you look at the profile of organisms, these organisms are community acquired profile. This assay is not meant for shunt infections. It is not validated for shunt infection. In fact, it doesn't have the organism profile also for shunt infections. So, how does enterovirus detection helps? So usually what happens whenever we are doing sepsis workup in children, so there is hospital admission required, and maximum cost, we also need to talk about cost, particularly when we are managing patients. So the cost, maximum cost accrued during the first day of admission. So when you are running the test right away, you are actually doing away with unnecessary admissions and costs. Okay, so there are certain merits that I want to highlight because we start with empiric antibiotics. We do not, tend to continue when we do not have diagnosis. So the BioFire would still come positive even if you are giving antibiotics, because it would detect the dead or bacteria or the viruses as well. So there are two questions that need to be answered. Do we need a diagnosis for aseptic meningitis? The answer is yes, because in aseptic meningitis, you do not necessarily need an admission, you do not need a CT scan, you do not need a radiological investigation, because in its pure form, meningitis is mostly, in aseptic meningitis, is purely benign, and that's where you do not require empiric antibiotics, antivirals, as well as admissions and ancillary testing. So this is one study in the clinical infectious diseases where in encephalitis they did not have an etiology because they did not use multiplex PCR testing, and there was 58% times no etiology and 46% times there was bad outcome. So in a critical scenario like encephalitis, not knowing what organism is causing the infection is actually a disappointing statement. So when do I run the BioFire? Should I wait for the CSF microscopy or the CSF biology to tell me? So one particular scenario I have talked about where hypoglycorrhea can also be viral. There are other features as well. For example, if I am talking about only pleocytosis, in children, pleocytosis would not be there. So there are several exceptions where pleocytosis would not be there, and in our study we found out that 46% of neonates and 31% of infants did not have pleocytosis, but they had meningoencephalitis. So that is where they say that these are international guidelines that have come up with consensus that disregard pleocytosis. Even if there is no pleocytosis, go for HSV, VZV, enterovirus PCR, regardless of pleocytosis being there or not on the CSF microscopy. So I'll talk about certain limitations. We have talked about how BioFire helps, but to understand the test better, we need to understand the limitations also. So if a patient is having cryptococcal infection, which is the best test that would help me in diagnosing cryptococcal infection, it is not a PCR, but it is actually cryptococcal antigen test. Why? Because Cryptococcus produces that antigen, that capsule in abundance, and that's where cryptococcal antigen is helpful in diagnosing the infection. So where does PCR and culture stand? So culture is important for monitoring therapy. So if what is seen in a highly sensitive test like cryptococcal antigen test, it is seen that even after 6 months of therapy, CRAG will keep coming positive. So in those cases, you need a culture for cryptococcus. Also in differentiating between iris, that is immune reconstitution inflammatory syndrome in patients getting heart therapy. So in those cases, again, a cryptococcal culture and is better than a CRAG, because CRAG will keep coming false positive. So where does the BioFire help? BioFire would help again in patients who you're not ordering the India ink or the cryptococcal culture. As an unsuspected pathogen, it comes up. So there it would help, and also BioFire has shown very good correlation in HIV patient populations, where again you need to differentiate between iris and relapse. So that's where again the BioFire has helped. So finally, there is one condition which is again herpes simplex encephalitis. In the initial time, it requires time to multiply in the brain parenchyma, where in the first 48 to 72 hours, the CSF biology would be normal, even the PCR would be normal. Not only BioFire, all PCRs would come false negative. So because of that, all the guidelines say that repeat CSF HSV PCR after 3 to 7 days. Do not stop the acyclovir if there is clinical suspicion of encephalitis. Don't stop the acyclovir. Revisit the lumbar puncture, revisit the test, and because there is false negativity not only in BioFire but in all PCRs, as well as CSF biology can also look normal in the first 48 to 72 hours. So with that, there are several publications. One publication that has recently come up from KIMS Trivandrum, where they found out the ME panel, they gave 30% positivity rate. So there are several publications coming up. One is from Max Saket, the other was published in Indian Journal of Critical Care, and the latest is in the KIMS, from KIMS. And there is also publication on cost effectiveness, which is always a concern. Now I'll rush through the BCID panel. This would be my last panel, sepsis, of course, a conundrum. It is always a gray zone because it does not have a linear course. It is actually body's immunity going into an overdrive because of the underlying infection. So sepsis is difficult to diagnose. Sepsis is a medical emergency. Every hour of delay causes mortality by 7.6%, particularly in septic shock. Sepsis is difficult to treat. You have to start empirics, but you have to balance it out with antimicrobial resistance that it may contribute to. And of course, sepsis is costly. So blood culture so far remains the best method because the biomarkers have their own caveats. So blood culture, what is the most important variable? So every clinician says we send blood culture, but they are mostly negative. So why is it so? Because unlike other samples, so other samples, other infections, they are localized infection, whereas bloodstream infection is a generalized systemic infection. So there is a lot of dilution of the organism that happens when it is spilled out. Secondly, blood has complement, lysozyme, antibodies, antibiotics, phagocytes. So all of that leads to a very low pathogen load in the blood. So that is less than 1 CFU per ml. In children, the load is still higher because the immunity is not so robust. So that is why this, the dictum is that you need more sets of samples. The higher the sets of samples, the more is the likelihood of you clinching the diagnosis. So multiple sets of paired blood culture. So minimum 2 sets, ideal would be 3 sets. And what does the set what should that set consist of? It should be one aerobic and one anaerobic. So why should I add an anaerobic? Firstly, of course, anaerobic should be used for detection of anaerobic, but the myth is anaerobic doesn't only detect anaerobic organism, it also detects facultative anaerobes. And facultative anaerobes, as this study was recently published, which took into account 150,000 blood culture bottles, and what they found out, 18 out of 20 organisms that are there on the list are actually facultative anaerobes. And these are the most common bugs in any hospital. So they when you are using that combination, you are not only decreasing the time to detection but also increasing the yield. So that's where the blood culture is helpful, and this is the only panel which is not directly run on the sample. This is run on a positive flagged bottle. The principle is the same. If I run it directly on the sample, it would lead to false negative because the pathogen load is so low. So you need to incubate it only when it flags positive, you run this culture. So how does it benefit? How does the BCID panel help? So, of course, there are guidelines which say that use rapid testing and multiplex PCR, with surviving sepsis campaign guidelines say that polymicrobial bloodstream infection. So previously it was thought that bloodstream infection is only monomicrobial. However, there are statistics which say that up to 10% of times or even more, there could be polymicrobial bloodstream infection. So in the standard of care traditional testing, what happens, the blood culture is collected, the microbiology lab incubates it in the automated system. When it flags positive, it is taken out. By protocol, a gram stain is done, culture is done, and that bottle never goes back. And no one revisits that bottle because the conception that it is monomicrobial. But what happens is, when we are doing that gram stain and culture, there are certain organisms that may be below the limit of detection of the gram stain and culture, where PCR, because of its higher sensitivity, would be able to detect. So this is one case I talk about which is published. This is an immunocompromised patient. This is a patient of prostate and bladder cancer, presents to the onco clinic with sepsis, and the patient, the blood culture flags positive, and the gram stain is done. Gram stain detects only gram-negative bacteria, but the biofire says it's Enterobacter cloacae and Candida parapsilosis. The stewardship team says that let's start for antifungal as well. However, the clinician says it must be a false positive, and because it is only gram-negative that was detected on the gram stain, we give only ertapenem. So the patient is discharged, but however after 10 days the patient returns, and this time the patient is more severe and the KFT is off the roof, and now again the blood culture is done. The ertapenem was continued for 10 days, the gram negative has gone, but the biofire detects the Candida parapsilosis again. Now culture is also detecting Candida parapsilosis. So with detection of Candida parapsilosis, because it is more sensitive Candida, patient was started on fluconazole and the patient responded. But the highlight is that the Candida was not a false positive because of the lower sensitivity of culture and traditional method, it was missed. So polymicrobial detection, particularly in immunocompromised populations, is very important. So this was published in the journal that I showed. So GI panel quickly, this is the GI panel that was launched in 2022 for septic arthritis and prosthetic joint infection. We do not have any orthopedist here. Okay, so I'll rush through it. GI panel, there are two cases I need to highlight. Where do I use it and why do I use it? So this is the profile of the GI panel, and where these are particular conditions where it needs to be used. If there is dysentery, if there is community acquired diarrhea for more than 7 days, persistent diarrhea, severe immunocompromised populations, travelers, in those cases, because usually the GI infections are self-limiting, but in these particular conditions it may be helpful. So this is one case where I present, this is child presenting with fever, loose motions, abdominal pain, and CRP is high. So this is a picture, it can be either infection or appendicitis. So a biofire can help because it detects Yersinia. So Yersiniosis often mimics appendicitis. So what does this help the clinician with? You do not need an appendicectomy. You can do away with an unnecessary surgery early and start the right kind of management. Secondly, this is a hemolytic uremic syndrome. This patient has HUS, as you can see classical picture. So HUS is one condition where diagnosis is very important because it is one bacterial infection, it is one condition caused by bacterial infection where if you start antibiotics, it would rather exacerbate the condition. So that's where again diagnosis is very important. And there was Indian Journal of Nephrology, they came up with what are the guidelines for HUS in 2023, and they said that detection of STX1, STX2 gene helps in diagnosis of HUS, which is there on the BioFire panel. So when I talk about the BioFire, this is the extensive validation that has gone under, the panel has undergone for all the parameters. For the CSF, as you can see, it was 1560 samples were submitted to the FDA. So this is the kind of validation that has that the assay has undergone for the high sensitivity and specificity that it provides. So three panels give you AMR genes: the BCID panel, the pneumonia panel, as well as the JI panel. So that would be all. Of course, Dr. Adarsh has talked about where it is, if it's not there on the panel, for example, Acinetobacter OXA23 is not there. So we need to know the off-panel mechanisms. A BCID panel giving all negative, but a gram-negative bacteria getting detected on the gram stain could mean Burkhold area. So those are the kind of mental mathematics that need to be done when we are looking at the report holistically. So with that, I would like to conclude that without diagnostics, without accurate diagnostics, medicine is blind, and that is where diagnostic stewardship is helpful, and multiplex PCR testing like BioFire really helps. Thank you so much.
Thank you, Dr. Devjani, for the nice presentation. If there is any query, quickly, because there is already time constraint. Otherwise, you can verify with her later. I invite Dr. Elizabeth Joseph to come over and hand over a small token of appreciation. Thank you, Dr. Elizabeth Joseph. Thank you all for coming. Have a nice day.